Sounds good. Hi, everyone. This is Yoshen from Tri-County Health Department in Colorado. Welcome everyone to participate our session, the data visualizations, which is definitely a topic that a lot of people are interested in and learning more, especially during the COVID, and how do we make good data visualizations for our partners out there and what we can learn from other partners across the country. So welcome everybody here. And then I know you all are very busy right now, so I really appreciate your participation. So as some of you just heard me saying today for this session, we have 4 different speakers and we have 3 different topics for you. We will go through each session for speakers to introduce themselves, and we will save all the questions to the end of this session. And I'm the moderator today, and we also have another moderator which will help facilitate question session today, which is Crystal. And I want to introduce myself to all of you. I'm from Colorado, and I'm the Syndromic Surveillance Program Supervisor for Tri-County Health Department. And I love syndromic surveillance, and I have been working on this for 7 years now. So I am pretty excited about today's session, and I will turn it over to Crystal to introduce herself before we start the presentation. Crystal.
Thanks, Yoshin. Hi, everyone. My name is Crystal Collier, and I am the Syndromic Surveillance Program Coordinator for the Arizona Department of Health Services. I'm very, very excited for all of our presenters today, and I'm happy to facilitate questions. So I will turn it back to you, Yoshin.
Sounds good. Thank you so much. And just a reminder for our folks here on the call, if you are not presenting right now, please mute your line, and so we don't have a lot of background noise. Thank you very much. So for today's session, as you can see on the screen, we have Amanda, Michelle from Alabama, and another Michelle, and Ethan from Houston. So now I want to appreciate all of our speakers again that they present this awesome work from their jurisdiction during this crazy time. So I will turn it over to Amanda from Washington State Department of Health.
Yeah, hello. So I'm going to steal the screen. I'm going to present my own slides, and then I have a dashboard that I'm going to share with you. So as my friend Yoshin said, my name is Amanda Delina Morse. I'm an epidemiologist with the Washington State Department of Health in our Rapid Health Information Network program, which is the Washington State Syndromic Surveillance Program. And I'm going to talk a little bit, not just about like pretty pictures that we make in Washington, but also how we try to create data products, including visualizations, which are really accessible and useful for our partners. So a slightly different take on, I think, the theme of this group. So I want to start, though, with an acknowledgement that Washington State syndromic surveillance data are gathered in the unceded territories of 29 federally recognized tribes, as well as that of the Duwamish tribe, which is still fighting for federal recognition. I live and work on Duwamish land. I'm always so grateful to our tribal and urban Indian health partners for all of the work that they do and the collaboration that they're willing to engage in with us for the health of everyone in Washington State. So to sort of frame this conversation a little bit, a really common request that our program receives from partners is to have data and visualizations which they can use to communicate with members of their own community about health issues that they've identified as being particularly important to them, or to include in grant applications so that they can seek funding for health programs. This desire is often really complicated by the reality that for many of these communities, they have very small populations, and they also don't always have the staffing within their organization to analyze, visualize, and interpret this data. The map on the right is showing the population size for counties, and if you dig deeper, even in our larger tribal nations, like the Confederated Tribes of the Colville up here, or the Yakama Nation here, the number of people who are affiliated with those nations is quite small. So we're digging in really, really closely to small numbers. Some of this is smoothed over by the fact that in Washington State, we're able to share our syndromic data directly with those partners, but there's still sticky bits with it. So we have sort of two ways that we help communicate data with partners. One of them is to use MyEssence dashboards. This is here on the right, a screen catch of my own MyEssence dashboard library, where I have two different categories that are really intended for local health jurisdiction and tribal support, where dashboards are made either specifically for a county or there's sort of COVID-related local health jurisdiction or tribal support. MyEssence dashboards have a lot of reasons why they're really great to use for this purpose. They're easy to build, they're easy to share. There are lots of really flexible display options, including data details outputs so that they can review the record level details for those visits, or you can have time series graphs, or you can have tables. It's really based on whatever they need, or you can do mapping if they need to do zip code level analysis, because that is the type of granularity that they need, which is often really helpful, particularly for tribes, since sub-county analysis is going to be really important for them. When we're building these and we're having the conversations with partners, I find it always really helpful to start by asking questions about what their current processes are so that their workflows don't have to change dramatically as they integrate these new tools. So asking them questions about whether they're doing trend analysis or they're doing case finding, asking them about the frequency and the medium of reporting findings up. So how do they talk to their health officer? How do they talk to others on their team? And then building tools that work around that. One of the other benefits of using MyEssence dashboards is that if you create it as a managed tab, then you or someone within your program can be updating it for them so that then they don't have to worry about doing the changes themselves as definitions change or they need a new condition added. You can do it for them, maintain it for them, and then it keeps that burden really low. So I have an example here. This is a dashboard that I created for one of our local health jurisdictions. I've blocked out what it is, and I've also blocked out the case finding. And what they were particularly interested in is general communicable disease case finding. So here on the left, you have these little widgets showing the time series graphs. And then here on the right, you see the data details outputs showing the parameters as well that are included in there, the diagnostic codes and the chief complaint terms, so that they can see really easily what's broken out here. This one was very long, so I had to break it into different lines so it would be a little more easily read. The benefit I found of having also here on the left these time series graphs is that these displays are only showing the previous 7 days, but some of these are really heavily leaning on diagnostic codes, which might not be added within 7 days. So being able to look back and say, oh, you know, I didn't see anything last week for this, but it looks like now there's a data point there. What was that? And then also here breaking out people who were seen in that county versus residents of that county who were seen outside the county. There have been some other workshops I know looking at data sharing and cross-border stuff. So that sort of goes along with that. We also do support for trend analysis. This is another dashboard that we've made that we call the COVID Quick View dashboard. It's available in the MyEssence dashboard library for anyone who's interested in it. And it's primarily showing trends, has some maps, it has these data details outputs that I've hidden here because they contain PHI, but really building it based on what local health jurisdictions and tribes have been telling us that they want to be able to see and view very quickly so that then they can say, I'm not worried about anything here, move on with my next task, or, oh, that looks frightening, I need to go in and I need to investigate that a little more. Of course, though, not everyone is able to access the data directly, or they might not have capacity to do it because they're wearing too many hats in their organization, they're very busy. And so in those cases, we have a second approach where there's packaged reports and displays. So we lean really heavily on Tableau and R to build these, particularly for creating timely and tidy visualizations. So mapping and simple graphics, full reports like this one here that I have on the right. And then, as with MyEssence, it's really important that you're asking questions about what it is that they want to do, how often they're going to need it updated, who is going to see it and what they're going to do with it. And if you find that frequent updates are going to be necessary, we've found it really helpful to automate as many of these processes as possible in R. We play well with others and are happy to share the things that we've made. So if you want access to some of the code that we've made, we're happy to share that with you. But I have a dashboard that I can walk through super quickly. I did not make this, my colleague Cody Carmichael did. That's why it's really beautiful and nice. So you can see here, there's this brief introduction. This is made in Markdown. There's a brief introduction here talking about what's going to be included in this dashboard, looking over here in this tab, the burden of traffic-related injuries. So this is using All Traffic version 2. Then we have some monthly trends, so we can see all traffic-related ED visits, the same but among adults, the same but among children, and then a nice table here showing the count and percentage for all traffic-related adults and pediatric visits. We can see after that some different demographic breakdowns. This is, pretty self-explanatory there. We also are really into time of day, trying to pinpoint periods of time when people are more likely to seek healthcare and perhaps more likely to have experienced the injury during that time window. This is looking by 2-hour segments. I really love the time of day graphs in Essence as well. If you haven't used those, I find them fantastic. And then we do a little bit of mapping. You can see some zip code level analysis here. There's code built in for suppression of values less than 10 or any rates or percentages derived from them. And then here, looking more closely at some pedestrian level data. So with that, I imagine that I am very close to time. So if you need to contact me, my email address is my first name dot my last name at doh.wa.gov. Thank you so much.
Thank you, Amanda. And just a reminder that we will save all of the questions to the end. And then so we are ready to turn over to our next speaker, Michelle from Alabama. Michelle, are you ready?
Hi, Yoshin, can you hear me?
Yes, I can hear you.
Great. Thank you. That's a very good presentation. It's going to be a tough act to follow, Amanda. Okay, well, really quickly, my name is Michelle Vickers, and I work for the Alabama Department of Public Health as a public health research analyst. I've been with ADPH since February 2011, and I've spent the last 5 years in syndromic surveillance. And I have my earned bachelor's degree in business administration from a very empowering HBCU, Morgan State University out of Baltimore, Maryland. And I have my master's of public administration from the University of Baltimore, also in Maryland. And I am the co-chair of the Data Quality Subcommittee as part of the CSTE facilitated NSSP Community of Practice. Next slide, please. Okay, we are reminded that of the saying that a picture is worth 1,000 words. And we've learned that data visualization provides an engaging way to communicate a data-driven information. What we have here is our COVID-19 risk indicator dashboard. This dashboard provides data and surveillance information about the coronavirus disease 2019 in Alabama. Data used to produce this dashboard are from the Alabama NEDS-based system, which is ALNBS, and our disease reporting surveillance system, and also from the Alabama Syndromic Surveillance System. And the Alabama Department of Public Health actually uses this data and metrics to make recommendations to assist the governor's office, partners, and stakeholders across the state in making decisions about safely reopening Alabama. So this is our general COVID risk indicator dashboard. Next slide, please. Okay, now what we have here is one of our data visualizations that we use for reporting. This was created in Tableau. And since data visualization is a key component of exploratory data analysis, which provides properties where the properties of data are explored through visualization and summary techniques. So data visualization is really great for helping us discover biases, systematic errors, mistakes, and other unexpected problems in data before those data are incorporated into potentially flawed analysis. So this visualization was generated using Tableau, And what we want to do here is basically what can you glean at a glance. We want to be able to capture information quickly. At a glance, you can actually see our public health districts counts and the general trend analysis. You can actually glean at a glance that our Northern District has the largest numbers of CLI records, and our Southeastern District has the smallest number of CLI records. We also can glean at a glance that there was a spike noted in the CLI observations occurring after our first positive COVID-19 was identified. We can also glean that there were a possibility of COVID-19 circulating prior to the identification of our first positive case, which we have indicated in the graph at the bottom. We have March 11th, 2020 as the first time that our first COVID-19 positive case was indicated in our syndromic surveillance data. And you can actually see a clear spike after that. It just, because we know what we're looking for, apparently it just started showing up a lot more quickly. And so again, we're just going for what we can glean at a glance with our data visualization. And this information is generated from our Essence system, and it's just interfaced in Tableau. So we go ahead and send that up to our epidemiologist. Again, I'm an analyst, I'm not an epidemiologist, which I usually lead with. And then that way we can give them an idea of what the syndromic surveillance data is looking at. And this is just our trend analysis from January of 2020 to June of 2020. And even though we had our first positive case identified March 11th, we like to show the previous 3 months so that we can kind of gauge what we're looking at. And if you want to go to the next slide, please. Okay, now this is a generated plot graph that I actually was able to generate in using R, and I converted it over to Tableau. I use the R because it's easier for me to communicate information that's difficult to extract from tables or raw data, and R works a little bit better for me sometimes. And I was able to go ahead and replicate that in our Tableau interface. So again, we're trying to go with what we can glean at a glance. Just really quickly here, our gray line indicates our state CLI rate, which is our COVID-like illness rate. And we also have indicated our 8 public health districts with different colors to make it easier to capture. And just really quickly, the first thing that we can notice, the county with the largest population is Jefferson. I'm using the initials here for the size that we have. So if we look all the way over on our x-axis to our population, you see that Jefferson actually is the largest county population, while green is our smallest county population. We also know that our county with the largest CLI, which is our COVID-like indicator count, is Montgomery, which is the NT initial with the blue dot there. And our smallest is Claiborne. So these are, again, just things that we can glean at a glance from just one particular graph. We also note that our districts, counties with the greatest population, of course, is Jefferson. Jefferson is one of our single county districts. So that sometimes it messes with the numbers a little bit because it's a county and it's a district by itself. So we just have to make that notation when we're analyzing our data. And we can also see that the West Central District contains Greene County, which has the lowest CLI counts. We also see that the district county with the highest CLI numbers is our East Central, is where our Montgomery County resides. And Northeast has the lowest number of CLI counts, and that's where Claiborne County resides. Again, gleaning at a glance, you can show that we do have a positive linear relationship between the number of CLI in a county as well as the population of a county. We can also see how the CLI rates vary across the counties and across the different districts by examining their proximity to the state CLI average line, which is denoted by the gray line. We are showing that Lowndes and Montgomery counties appear to be the furthest away from the line, suggesting that these two counties have the highest CLI rate, while Claiborne and Escandia are the furthest away from the CLI line below, showing that they have the lowest CLI rates. And that can actually be verified doing a least squares estimate, which I didn't want to get into and trying to be brief with our time. So that's what we actually can glean at a glance when we have a look at this particular graph here. And you can go to the next slide, please. And finally, again, gleaning at a glance is our theme here. What I've had for you is a scatter plot matrix, and this is good for helping us to visualize buy rate relationships between combinations of variables. Here we have basically our three numeric continuous variables of interest, which is our CLI count, our CLI rate, and our county level population. We just previously discussed the relationship between our CLI count and our county population, which was a positive linear relationship, and the total number of CLI and rate. Those are another relationship that we like to speak about because we want to make sure that we're not just looking at counts, but we're also looking at the rates. And we noticed that when we did the linear analysis for our total number of CLI counts and our rates, it was a poor association, but it was still a positive linear relationship. It's just that it had a low association causation. One of the third levels of the relationships that we like to look at is our CLI rate versus the county population. And it actually does show that it has a negative relationship because it's going in the opposite direction. And let me see, that's going to be the one line that's going to the left. And we just basically identified that there's really not an association between those two parameters, but we actually put it in our scatter plot matrix so that we can show that there's a difference between the analysis if it's a positive correlation, if it's a negative correlation, or if there's any association at all. And again, the scatter plot matrix just allows us to show the information together in a more structured, visually pleasing way because each scatter plot visualizes a different relationship between the pairs of variables. So this way we can easily explore the relationships in one chart, again, giving us the opportunity to glean at a glance. And all of the analyses that were in this particular graph and the previous graph were conducted using our programming and statistics. So there's a whole bunch of suppressed linear regression analysis that are probably going to bore everybody to death in this presentation since we're just doing visualization, but I'll be more than happy to share that to anyone who would like to know the numbers. And if you go to the next slide, please. And of course, I would just like to thank the Alabama Department of Public Health, Infectious Diseases and Outbreaks Division, the National Syndromic Surveillance Program Community of Practice, the Council of State and Territorial Epidemiologists, and of course, the Center for Disease Control and Prevention for the opportunity to work and present on syndromic surveillance. And thank you for having me.
Thank you, Michelle. Thank you, both Amanda and Michelle, for the great dashboard. I believe everyone learned a lot from you guys. So thank you very much for presenting. Last but not least, for Houston's presentation, for Michelle and Yingfan on this call, and then to present their work to the group. Now I'm turning over to Michelle.
Hello. My name is Michelle Carr. I work for the Houston Health Department. I have a master's in applied epidemiology from the University of Arizona, and I currently work in the informatics program. I work on a CDC-funded molecular HIV surveillance project. I also work with the informatics department to analyze data, create reports, maps, and other visualizations, and I also volunteer with the Houston Viral Hepatitis Task Force. And my colleague, if she wants to introduce herself now.
Oh, sure. I'm Yifan. I worked as an epidemiologist at the Houston Health Department and specialized for report automation and visualization. I graduated from University of Texas Houston Health Science Center School of Biomedical Informatics with a master's degree and currently registered as a full-time PhD student. And with the research interest in public health informatics and syndromic surveillance. And I'll turn it back to Michelle.
Next slide, please. So the objective of our presentation is to no, that's fine. Is to present a novel visualization tool that can be used to effectively share syndromic surveillance analysis. Next slide. So a little bit of background. On March 17th of 2019, a massive petrochemical fire erupted, and it continued to burn for 4 days. And even continuing those 4 days, there were still some effects from the long-lasting effects from the fire. To assess the potential effect of fire-related breathing problems on the nearby community, the Houston Health Department informatics program collaborated with the Houston Health Department Environmental Health to collect both syndromic and environmental data to use with a visualization tool in ArcGIS. Next slide. So we collected data from a variety of sources. We collected data from surveillance systems in the Houston Health Department. We used the Southeast Texas Syndromic Surveillance System, or STSS, and also our Houston-based system, the Houston Electronic Disease Surveillance System, or HEDS. The syndromic surveillance data is essential to understanding the health status of affected communities, both during and after a disaster such as the fire. We also collected environmental data. We used the air quality data that was collected from 7 different environmental sensors from the Texas Commission for Environmental Quality, or TCEQ, from March 17th to March 25th of 2019. And then we used ArcGIS to overlay the air quality data with the STSS data, and we used an ArcGIS inverse distance weighting tool to estimate the air quality based on the average environmental readings for each day. Next slide. So just a little bit of information about the IDW, or inverse distance weighting tool, that we used. Inverse distance weighting interpolation is a method that estimates cell values by averaging the values of sample data points in the neighborhood of each processing cell. The closer a point is to the center of the cell being estimated, the more influence or weight it has in the averaging process. And then this is just a picture of the settings that we used for our IDW interpolation. Next slide, please. So our results are findings based on the 5 sensors that were visually displayed. We got a detailed presentation of the area of interest. 7 maps were created, and these maps demonstrated that air quality on the northwest side of the incident had the greatest average reading, and the trends in the air quality data readings were evident in the map, and we'll show you some of the maps in a minute. Basically, our findings found that the readings increased, the environmental readings increased after the second day the second day was March 18th. They peaked on about the 20th of March. Then the environmental readings, started to decrease on the 21st. And then they continued to decrease on the 24th and 25th around the incident area, but they actually remained steady on the outer northeast portion of Houston. Next slide, please. So we also looked at chief complaint counts for respiratory related illness, and these were highest in the first 2 days. Overall, the trend in respiratory illness complaints showed about a day lag, but they had a more long-lasting pattern than the air quality trend. So as you saw the air quality trend decrease, the respiratory complaints still lingered for a while before they dropped off. Based on the map, the respiratory related visit trend peaked on about the 21st at 7 conterminous zip codes surrounding the incident, and each area had greater than 8 respiratory complaints. By the 24th of March, the respiratory complaint trend was falling overall. However, the map showed that high complaints in the conterminous zip code patterns had spread to other northeast Houston areas, and this pattern follows the air quality pattern in the last 2 days. So conclusions, after the Deer Park fire, next slide. After the Deer Park fire, the air quality had a sharp and narrow tide compared to the dull and long-lasting respiratory complaints tendency. And in the next slide, my colleague will discuss the maps.
Hi, sorry to interrupt. This is Yoshan. For the interest of time, that you only have 3 to 4 minutes left. So just a reminder. Thank you.
Thank you. Yifeng?
Am I muted?
No, we can hear you.
Okay, so I will walk through the 7 maps we created. And as Michelle mentioned earlier, each map mainly has 3 layers. The sensors, which are these pin dots labeled with the sensing area name, and their air quality represented by the categorized greenish or yellowish color, and the count of respiratory complaints in each zip code, represented by the categorized grayish color in this map. The categories in the air quality monitoring data were determined according to the internal recommendations and based on the natural breaks in ArcMap. And these breaks were inconsistent for air quality as the situation arises. But the respiratory complaints breaks were consistent, and the last category is anything above 7. So in this map, air quality looked peaceful, max was 12. Please keep in mind the air quality was using the average reading, and the max respiratory complaints were 14. And next, please. And for this second day map, air quality reading of the west of the event has increased, and max was around 16, and the respiratory complaints increased to 23. Next slide, please. On the 19th, the air quality high reading spread to larger area, and the complaints maxed to 25. And next, please. On the 20th, the reading was peaked. It looks less serious because the categories was changed. But if we didn't change it, it would be harder to identify area that the mostly affected. And the respiratory complaints maxed to 19. And next, please. Air quality reading started decreasing on the 21st. The respiratory related visit trend peaked on this day at 7 conterminous zip codes surrounding the incident, and each had more than 8 respiratory complaints. And next, please. And air quality reading continued the decreasing on the 24th around the incident area, but remained steady in the outer northwest Houston. The max reading was less than 10. However, the map showed that the high complaints contaminants zip code pattern had spread to the outer northwest Houston in a zoomed out view. And next, please. And on this last day of our monitoring, air quality data reading continued decreasing on the 25th around the incident area, but remained steady in the outer northwest Houston. The max reading was less than 10. And again, the map showed that the high complaints conterminous zip code patterns had spread to the outer northwest Houston. And this pattern follows the air quality area pattern in the last 2 days. And next, please. The limitations include ERs surrounding the chemical fire have not been fully onboarded to STSS. Data points were dependent on the reporting timeliness and may have been underrepresented. They also change over time. And observations of 22nd and 23rd were missing. The Aldine monitoring site was under maintenance and data was unavailable for March 18th to March 25th, and caused IDW2 to interpret reading as 0. The air quality data contours were created using IDW2 in ArcGIS 10.5 without considering environmental conditions such as wind speed, humidity, temperature, and so on. And next, please. Lessons learned from this event. Environmental surveillance data and health surveillance data can be combined for resource allocation purposes, and standard categorization needs to be established for easy interpretation. This air quality plus respiratory complaints combination can be applied to other environmental and health issues such as wildfire smoke and respiratory symptoms, temperature and heat-related illnesses in the summertime, parasite infectious diseases after hurricane. And next, please. And this concludes our presentation. Thank you for listening.
Thank you so much. I think we are right on time. And thank you for all the presenters for their hard work and showing us this amazing data dashboards and different usages of the data in essence. It's really amazing. So I think we are going to transit this session into the question session. And Crystal, thank you so much. And you can pick it up now. Thank you. Crystal?
Today and what they've been able to share and trying to connect after today's session. We'd like to open it up. So what questions do you have in the audience? I believe you should be unmuted and able to share your questions, or you can drop them in the chat box and we can ask our presenters. Is one of the things I noticed through all three of the presentations was the mention of having this timely data to assist them and especially local health departments throughout these different presentations. How has the availability of this data and being able to use these visualization tools help you better communicate what is going on during that particular situation? And this is
Hi,
for
Crystal.
any of our...
Michelle, can you hear me?
Yeah, go ahead, Michelle.
Oh, just really quickly, with these opportunities to share, I just wanted to let everyone know that Amanda from Washington was kind enough to share her Essence availability for some of the dashboards. And so Alabama did take that opportunity to replicate some of the dashboards that they had created for their COVID surveillance. So these opportunities to share and platforms like this can give everybody ideas and give you opportunities to reach out. So if you see something that you'd like and you want to learn how to do that for your state, you know, Amanda was kind enough to share that with Alabama.
Thanks, Michelle.
Oh, thanks. Yeah, my Essence Dashboard Library is just like where my work goes to die. So I'm glad that people are finding it helpful and not just go wasteland with my projects.
It was not. We you know, resurrected it and utilized it as well. Thank you.
So maybe thinking about that and what Michelle and Yifeng just presented was saying there needs to be standardization for some of these things. I know we've got a couple of air quality dashboards that have been shared as My Essence dashboards in the library, but how would having some more of these visualizations or seeing what others are doing support some of the use cases that you all shared, or help us be better prepared to use some of these different data sources and how we visualize them for situations like this that might happen in the future?
Can you repeat your question? I was kind of lost.
So I think I'm trying to pick up on what Michelle Vickers from Alabama is pointing out, that some of the things that Amanda Morris presented in her Essence dashboards are things we can download as a resource and to help us with more of that standardization of how we visualize some of this data, or how to make it easier to do what others are doing. And I saw some of your lessons learned from Houston, that there may be some opportunities where standardization could help through some of this. So I'm wondering if, from your experiences in Houston, having more examples of how to visualize the data and standardize using the air quality and, say, the health data from Essence through some of these My Essence dashboards or other tools, and making them more available might be something to help others if they face a chemical fire in the future or something like this that might warrant the use of these types of data sources. I'm guessing, Michelle and Yifang, that you both had to work together with your team to create things that weren't available. If there was more examples or more ways to standardize this, would that be helpful?
Sorry, I was muted. But yeah, I think that the more opportunities we have to come together and the more opportunities we have to share, what we have been working on, it allows us to create those standards and, just looking to see what others are doing. Because like when we first started working on these maps, we were learning from many different angles. We were learning how to use the data. We were learning how to use, the IDW tool. So it was a learning process for us. And so, yeah, having more access to what other people are working on, and the more we collaborate with each other, I think those standards will develop over time. Did that answer your question?
That did. I'm actually taking notes on some of what you said, because I'm bulleting marks that I would like to follow up with you all based on what you shared today. From our Arizona side, I see many benefits from this. I guess thinking of what you're saying too, Amanda Morris, like, you've done a lot of developing these dashboards, but I don't know that there was a blueprint for you necessarily, but you're definitely providing one for us. How has some of this been helpful for you, or in terms of building these dashboards so that you can visualize the data and make it more accessible to those local health departments? How could having more examples of these tools for yourself, or providing those to others and getting some of this feedback, continue to help you provide the service of delivering these types of visualizations?
Yeah, so I mean, for us, it's sort of an iterative process. And I talked about some of it during my presentation, making sure that we're constantly having conversations with our partners about what it is that they want to do and ideas that they have for how they could best accomplish it, and then trying to build things around that. So sometimes we definitely do strike off in the wilderness and just build things and hope that people like it. But even then, we do try to solicit feedback as often as we can to make sure that those products are actually useful and not just us spending time making things. Did that answer your question?
Yeah,
a lot of
I think if we only had more time, there was more we could dig into, because I see there's just so many questions after all of your presentations. And then we are pretty much right at time. I guess, is there anything before we end our session that you all would like to share with the audience, or food for thought in creating some of these visualizations and leaving to today's session and moving forward?
I think it's helpful to have a local community of practice. As Syndromics transitions from being primarily a data source for epidemiologists and informaticians and into one that is increasingly being used by people who don't have advanced statistical training, making sure that the things that we're building and the conversations that we're having stay accessible. So having local conversations with within your jurisdiction and the jurisdictions around you about what other people are doing and sharing those things together. We have the national community of practice, but here in Washington, we also have a local community of practice that we've had since like mid-late 2016. And it's been really, really helpful to have that forum where we can share and lean on each other.
I like that idea. That's that's a great idea.
If people are
Michelle,
interested in it, I'm happy to talk about what that process looks like for us.
I think so. I think it just giving our time right now, we have, thank you so much from many, many folks on this session. So I do want to thank all of our speakers. And if you want to continue the conversation, there's been some great opportunities in Basecamp. This session is being recorded, and we will be notified when the recordings are available and some of the other products from the symposium. So stay tuned and watch your mailbox for that. Just really want to thank you all for attending today, and please come back and join us for the rest of our sessions today.